So let's talk about the basics of the clinical reasoning and examination system. Well, rule number 1. We never start a functional examination with palpation. Never. This is one of the diseases of many physios all over the world. The first thing they do, where do you feel the pain? There. Oh, and you palpate. No. There are a number of reasons why starting with palpation is not such a good idea. And one of those reasons I already explained in the film on referred pain. Remember? A patient could describe pain over here and he says, this point, this is a very sensitive point. That could be referred tenderness coming from the dura, which has absolutely no diagnostic value whatsoever. It's just misleading. But there are some other reasons why starting with palpation is not a good idea. Some structures are sensitive by nature. During the life courses, when I palpate, for instance, the tenoperiosteal aspect of subscapularis on you, most likely you're not going to like that. It's sensitive, but there's no lesion over there. Another little problem is the structure lies too deep. Tja, if it lies too deep, it's difficult to reach it. Perhaps another little thing, not only palpation for tenderness, but also palpation for segmental mobility in the spine, certainly in the lumbar spine, is highly irrelevant. Palpation for sacroiliac motion, which is so popular all over the world. I feel some hypomobility, I feel some hypermobility. Well, the only correct interpretation is I feel. No, I think I feel. This kind of testing has no relevance at all, but this is going to be a separate subject in another film. And then the last reason, where is my objectivity? If I palpate a certain spot and the patient says, oh, I have two options, I believe him or I don't believe him. But I don't have so much objective information. So those are a few good reasons not to start your functional examination with palpation. Yeah? So we're going to perform a functional examination. And the functional examination in the extremities is based on the principle of selective tension. And what is that? In fact, we're going to try to test every separate structure or every group of structures. We test a certain structure and we exclude another structure. The only little problem is don't use too many tests. This is another disease in the big manual therapy world. Test, dozens and dozens and dozens of tests. But the question is, what do you do with those tests? What is the relevance of many tests? Are they really useful? For instance, shoulder. Yeah, very famous. Impingement test. Yeah, it's a relevant test for an impingement. But what does that mean, impingement? Something is squeezed in between humerus and acromion. That's not a diagnosis. The test says, okay, something is squeezed in, but that doesn't help me. I don't know what is squeezed in, supraspinatus, infraspinatus, subscapularis, bursa, whatever. So I need all other tests to find that out. So in our profession, there are so many useless tests. And another little detail, yeah, the relevance, I talked about it, but some tests have a very good sensitivity, but have a very poor specificity, or the reverse. So the challenge is to use tests which have a better quality. And that's not always possible. Yeah? Another little detail, don't jump to conclusions too fast. Yeah, we like to do that, huh? One positive test, haha, that's the problem. Look at the clusters, look at the package. Orthopedic medicine is about the package. You need a series of positive tests, a series of negative tests, and you're going to get a certain pattern, and then you have to interpret the pattern. And only in this way you can analyze clinical images in an objective way. Yeah? Soft tissue lesions are typical lesions. We're going to hear in the story, and we're going to find in the functional examinations, typical inherent likelihoods. And what does that mean? An inherent likelihood is the typical story for that particular lesion. And the typical clinical image, remember, clusters, the typical clinical image for that particular lesion. Huh? A supraspinatus lesion has a different clinical image than a subscapularis problem. So in our head, we have an expectation pattern. We like to hear the typical stories, we like to see the typical images, which of course I'm going to discuss during some other films, that's logical, but this is the key factor during the live courses. Yeah? On the other hand, you can also hear stories which are atypical, stories which don't correspond with what you expect. You see clinical images which are strange. That's not normal, that doesn't fit with this lesion or this lesion, and that's what we call inherent unlikelihoods. And if you hear and if you find inherent unlikelihoods, your first idea is perhaps it's not a lesion within orthopedic medicine. Let's not forget that orthopedic medicine is just a small part from the big part. Yeah? There are other options too. Perhaps there is a visceral lesion, a psychogenic lesion, other problems. So let's not forget that. I give you one example of an inherent unlikelihood. Let's imagine you have a lumbar patient. Yeah? And during the examination, lumbar patient is showing you a perfect flexion. Flexion, oh, no problem. And then at a certain moment, the patient is lying down on the treatment table and you do a passive straight leg raise. And what do you see? After 20 degrees straight leg, that's strange. Flexion in standing is good and a straight leg raise in lying is very positive. That's not normal. Flexion in standing is exactly the same as a straight leg raise with loading in the lumbar spine. So this is a contrast, and you have to do some extra tests to confirm the contrast. This is Cyriax. It's not about what your fingers do. It's about your ears and your eyes. What do you hear? What do you see? And you can collect a lot of useful information like this. So, a clinical examination, we always start with an inspection. Of course, you can notice the obvious things, yeah? It's red, it's warm, it's swollen, yeah, the inflammatory signs. Perhaps you see some bony anomalies, you see some color changes, you see some atrophy. Yeah, that could be interesting. But another little detail which may not be underestimated are the activities of daily life. And that goes a little bit further than we might suspect. Inspection starts in your waiting room. You say goodbye to your previous patient, you say hello to the next patient, and in the meantime you look, how is he sitting there? What is his sitting posture? Specifically for lumbar patients, very interesting. How does he stand up? How is the transition from sitting to standing going? And then you say, oh, please come in, have a seat. How does he sit during the history taking? How does he take off his clothes? When the patient describes in the history that he has a lot of problems with flexion, hypothetically, I have to see that during my inspection. What's the purpose of our functional examination? I would like to know who is responsible for the complaints, yeah? If possible, a specific diagnosis. But I not only like to know who, I also would like to know where. And here we have a huge contrast between extremities and spine. The clinical reasoning system in the extremities is different than in the spine. The diagnostic specificity is different. In the extremities, very often we reach a very targeted diagnosis, a very specific diagnosis. In the spine, a specific diagnosis is merely an illusion. In the spine, the diagnosis is going to be very specific. But let's come back to the extremities. So I would like to know where in which structure is there a problem. And sometimes we find in our examination what we call localizing signs. Yeah? And what is a localizing sign? Is a test that tells me which part of a certain structure is lesioned. More specifically, resisted abduction, maximal isometrical contraction. And let's imagine she says, ow. So which structure are you testing with abduction? You are testing deltoideus, you're testing supraspinatus. But let's imagine in the examination a little bit later you find that there is a painful arc. No pain, 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 no pain. Painful arc, what does that mean? Something is squeezed in temporarily between humerus and acromion. In combination with resisted abduction, it can't be deltoideus because deltoideus lies on top, it can't be squeezed in. So what is left? It should be supraspinatus. And which part of supraspinatus? This part of supraspinatus. The tenoperiosteal part. The painful arc in combination with resisted abduction tells you the problem is supraspinatus tenoperiosteal. That's a localizing sign. In the shoulder, painful arcs are very popular. You're going to discover in some shoulder films, and during the live courses, of course, that we have 6 different reasons, clinical reasons, for a painful arc in the shoulder. Let me give you another example of a localizing sign. Let's imagine resisted elbow flexion is painful, and resisted elbow supination is painful. So what do you think of? Think of biceps. Yeah? But let's imagine that you also find in the examination a painful passive pronation. And what can happen during the pronation, that the insertion of biceps on the radial tuberosity gets squeezed in. So the passive pronation is a localizing sign for a biceps lesion at the origin on the radial tuberosity. And this is the beauty in orthopedic medicine. When you find those localizing signs, it makes your diagnostic life a little bit easier. We don't have many tests. I told you before that we don't have to over-exaggerate with tests. There's no point in performing 45 different tests. How do you have to interpret that? Our main purpose is that we perform as less tests as possible and we get as much information as possible from those tests. But when we don't perform that many tests, you better make sure you perform your tests in a good way. And of course you're going to say, yeah. Yes, but let me tell you what I see on all courses worldwide. The majority of the colleagues, they still focus on the techniques. the treatment technique. And when they have to do the functional examination, oh, they exercise a little bit, but okay. I always have to emphasize to the colleagues, your examination is the basis of everything. When you don't perform a perfect examination, you're not going to reach a good diagnosis, you're going to mess up. So please pay attention to your examination. And sometimes we do simple silly mistakes. Huh? Let's imagine. Resisted lateral rotation in the shoulder. Come on, let's be honest. When you ask a patient to do a lateral rotation, the majority of the patients are not doing this. Huh? The majority of the patients are doing that. But what is that? This is deltoideus and supraspinatus. This is infraspinatus and teres minor. So make sure, check that the patient is doing the correct movement. So what are we going to do? First of all, you're going to block her at the shoulder, because when you ask to do lateral rotation and she has quite some pain, she can escape. I don't want her to escape. Another little detail, keep the upper arm against the body and show to your patient, I want that, I don't want this. So I'm going to block the upper arm with my body. And the final little detail, you don't give resistance over here, because then you also test wrist extension. You test a number of other structures. I don't want to do that now. Give your resistance over here. It's all in the details. And also here in the examination, ask neutral questions like we did, remember, in the history. Don't put words in the mouth of the patient. I presume we are all friendly people. Yeah, when you do an examination with your patient, you're always friendly. What is the number one question you always ask to your patient? Come on, let's be honest. You do some tests, and what do you ask to your patient? Yes, this. Does it hurt? As from now, you never do that anymore. That's not a good idea. Why? Let's imagine I'm your patient. Okay, and you do a test. I'm standing here. I have pain at rest. I don't do anything. I'm just standing here. I have pain. And you do a test with me. And you ask me, does it hurt? And I say yes. So what do you write down on your assessment form? Test positive. But you didn't know that during the test I had exactly the same pain as the pain I have at rest. I don't know the difference. I'm the patient. Yeah? You ask me, does it hurt? I'm honest, it hurts. So this is a very confusing question. So in order to avoid false positive answers, you don't ask that anymore, but you ask this. Does that change anything? If you do a test, before you do a test, what do you feel now? Is there any pain at rest? And then you do a test, and then you ask, does that change anything? And then the patient can say, oh yeah, I have more pain. I have less pain. No change. And if the patient says, I have more pain, don't automatically assume that he has pain where he had pain before. Always double check. Ask him where. Certainly with spine patients. They could have pain over here, yeah? And you ask them to do an extension, does that change anything? Oh yeah, more pain. Don't assume that there's more pain over there. Ask where, and then he says, here, in my leg. He does an extension and he produces leg pain. Diagnostically, this is going to have some implications in the future. Keep it safe, keep it simple. If you perform 10 tests, you're going to ask 10 times, does that change anything? And perhaps the patient is not 100% sure of when you do a test once. Okay, there's no rule that says you can only do a test once. Repeat the test and compare left and right. And finally, you're going to get a good answer from the patient. Yeah? One of the typical elements in the Cyriax clinical reasoning system is that we're going to make a distinction between, on the one hand, the contractile structures and on the other hand, the inert structures. So when you did your functional examination, then you ask yourself the question, what did we see? Does the patient have an inert lesion and or a contractile lesion? That's going to be the clue. Okay, what is the definition of the contractile group? Muscle belly, musculotendinous junction, tendon, and the insertion into the bone, the tenoperiosteal part. What's the definition of the inert group? All the rest. Disc, menisc, ligament, bursa, nerve, all the other structures. So the purpose is we make a distinction between two groups, and therefore we need objective clinical reasoning. Of course, the more difficult situations are the ones where the patient has a contractile lesion and an inert lesion at the same time. But that makes life exciting. So which tests are we going to use in our examination? Again, I'm talking about extremities. Yeah, in the spine it's a different story. We don't use many active tests. In the whole extremities, we have just a few active tests. Up, up, and up. That's it. In all the other joints, we don't use active tests. Why? There's a simple reason. Let's imagine the patient has an elbow problem, and I ask to the patient, okay, flex your elbow. And then he says, ow. And he can't go any further. What do I do with this information? This is useless information, because if he has pain and limitation, I don't know where it's coming from. Is it coming from an inert problem? Is it coming from a contractile problem? I don't know. Because during an active movement, both inert structures and contractile structures, they are active. So I can't make a distinction. So this is just a waste of time. So we're going to focus on passive tests. Passive tests are the main test for the inert structures. And what do we test? What happens with pain? What happens with range of motion? What happens with Enfield? More about that a little bit later. And the resisted tests are the main tests for your contractile structures, and we test two variables. What happens with pain? What happens with force? At all times, whenever you do a test, always ask yourself, what am I doing? What is my purpose? What am I testing? This is the basis of everything. But of course, a passive test can also stretch a contractile structure. And during a resisted test, you can also compress an inert structure. So sometimes there are some combination options, but this is a challenge we discuss at a later stage. But in general, passive test, inert structures, resisted test, contractile structures. And what about the Enfield? Well, the Enfield, this is something you can discover during a passive movement. You go to the end of the movement, the real end. Make sure you go to the real end, because some patients are really very mobile, and because of some technical issues, you don't perform the test like it should be done, but I refer to the films on functional examination for that topic. I'm going to illustrate that very, very beautifully in those films. And you just, at the end, you just give a little bit of overpressure and you check the feel. We're not going to overcomplicate. Keep life simple. You need to know what is the natural end feel. For some movements, the natural end feel is elastic. Rotations in the shoulder, that's elastic. Extension in the elbow, that's tuk-tuk, that's heart. Yeah. If you know what is normal, then you can know what is not normal. For instance, an elastic Enfield, which became a little bit harder. Typical with arthrotic changes. Or muscle spasm Enfield. You do a rotation and suddenly, ooh, muscle spasm, voluntary spasm, involuntary spasm, I don't care, muscle spasm. And muscle spasm means it's an acute lesion. Or a hard Enfield, for instance, hard Enfield elbow, which is not hard anymore, it became softer because one or more loose bodies are interfering with the mobility of the joint and provoke a softer Enfield. So sometimes the Enfield gives you accessory information. Again, I refer to our book on clinical reasoning, which you can download on our website. In this book, I give a description of a number of standardized examination protocols. For each joint, we have a standardized Cyriax assessment form. For instance, the basic shoulder examination is just 12 tests. And as I just discussed with you before, for instance, a passive test. A passive test, we have 3 variables. What happens with the pain, what happens with the range of motion, what happens with the Enfield. A resisted test has 2 variables. What happens with the pain, what happens with the weakness. And in this way, you can work in a standardized way and you can objectivate things more easily. Well, surf to orthopaedicdiscovery.com and get your free download of this clinical reasoning book, 156 pages full of information. The diagnostic system in orthopedic medicine consists of 4 steps. Let's imagine a patient comes to us complaining from pain in this area. The very first important question is, where is this pain coming from? Does it have a local origin or does it have a referred origin? In other words, is it a real shoulder problem? Or is it an acromioclavicular problem? Or is it referred from the cervical spine? Is it a nervous problem? Is it an internal derangement? There are so many options. So how do we know the answer to the question, is it local or is it referred? In most cases, we will know that after a specific detailed history taking. Then, of course, we continue with an inspection followed by a functional clinical examination. And very important in the functional examination is to use as less tests as possible. We really don't need any artificial hypercomplication. We don't need dozens of tests. We need a few tests, but what is very important, we need a relevant test. What about the inter-tester and intra-tester reliability of our test procedures? This is always a very important question. So, what are we going to do? We're going to test every structure separately or every group of structures. And let's imagine, okay, we performed 10 tests or 12 tests, whatever, depending on the region we are testing. And the patient gave some positive answers, he gave some negative answers. Then, of course, we have to interpret the test result. What did we find? Well, that's the second step. We have to make a distinction between, on the one hand, a contractile lesion and on the other hand, an inert lesion. What is a contractile lesion? Well, we are talking about lesions of muscle belly, musculotendinous junction, the tendon, the insertion. And what are the inert lesions? Well, that's all the rest. Disc, menisc, bursa, ligament, nerves, all this kind of structures. So I would like to make a differentiation between the 2 groups. Does the patient have a contractile lesion and or an inert lesion? If the patient has an inert lesion, then I ask myself the question, what did I see in the clinical examination? Which pattern did I see? Did I see a capsular pattern or did I see a non-capsular pattern? Well, the capsular pattern is typical for arthrosis, arthritis in a specific joint. What's the difference between the two? Well, the arthrosis, in that case, we're going to have the capsular pattern, a specific limitation of movement in certain directions. I discussed this in other films. With a harder Enfield. When we talk about an arthritis, then we talk about a muscle spasm Enfield. So most likely at this point in the examination, I know which structure or which group of structures is responsible for the complaint. Perhaps I don't necessarily know exactly where. Perhaps I know it is a supraspinatus lesion, but I don't know yet which part of the supraspinatus. In that case, the last stage in the examination is a selective palpation. A selective palpation in a specific structure we are looking for tenderness. But sometimes we even don't need palpation. Sometimes we find in the examination localizing signs. Those are clinical items we find in the examination that point us in the direction of a specific structure, a specific location. For instance, resisted abduction is painful. You think of a supraspinatus lesion, but you also find a painful arc and or end range pain on passive elevation. Well, because of the painful arc or the end range pain on passive elevation, it cannot be the muscle belly of the supraspinatus, it cannot be the tendon of the supraspinatus, it has to be the tenoperiosteal part. So the painful arc is a wonderful localizing sign, so we really don't need palpation anymore. This is a general system which we apply for diagnostics in the extremities. In the spine, the system is slightly different, which is also logical because those are totally different situations, totally different joints.